A young adult presents after falling onto their arm. I am showing you the radiograph of the humerus. Describe the findings.
All right, let's take a look. The radiograph demonstrates an extensive expansile lucent lesion involving the metaphysis and diaphysis of the humerus. There is marked remodeling of the bone with classic ground glass density matrix. Crucially, the cortex is thin but intact, with no cortical break, periosteal reaction, or aggressive features. These findings are highly characteristic of monostatic fibrous dysplasia.
What is the differential diagnosis for this presentation, and how does it compare to other forms of dysplasia?
The differential diagnosis includes simple bone cyst, aneurysmal bone cyst, non-ossifying fibroma and chondroma, and osteofibrous dysplasia. Osteofibrous dysplasia is almost exclusively confined to the tibial diaphysis in young children, presenting with anterior bowing and spontaneous regression. Fibrous dysplasia represents a developmental anomaly of osteoblastic differentiation, where medullary bone is replaced by fibrous matrix and immature woven bone. It can present as a monostatic form in 80% of cases, or a polyostatic form in 20%, which can involve the pelvis, femur, and facial bones.
I am showing you radiographs of the skull from a patient with a craniofacial variant. Describe the findings and name any associated clinical syndromes.
These frontal and lateral skull radiographs show profound asymmetric hemicranial sclerosis and expansion of the calvaria, sphenoid, and facial bones. This craniofacial presentation of fibrous dysplasia is termed leontiasis ossea. The marked osseous overgrowth can narrow the skull base neural foramina, causing exophthalmos, visual impairment, and cranial nerve palsies. When polyostatic fibrous dysplasia occurs unilaterally and is associated with cafe au lait skin spots and precocious puberty in young girls, it is diagnostic of McCune-Albright syndrome.
I am showing you tibial radiographs of a young child. Describe the findings and how they differ from classic fibrous dysplasia.
These radiographs of the leg demonstrate a well-defined, lucent, ground glass lesion centered in the mid-diaphysis of the tibia, associated with mild anterior bowing. The non-aggressive expansile appearance is classic for osteofibrous dysplasia. Unlike classic fibrous dysplasia, osteofibrous dysplasia is almost exclusively confined to the tibial shaft in pediatric patients, is characterized by a cortical rather than medullary origin, and frequently undergoes spontaneous regression as the child's skeletal matures.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with prior examinations to evaluate for stability or occult pathological fractures. I would suggest a full skeletal survey or a technetium bone scan to differentiate between monostatic and polyostatic forms of fibrous dysplasia. If the patient has persistent localized pain or shows aggressive features like cortical destruction, I would recommend an MRI or CT to rule out sarcomatous transformation, which occurs in up to 1% of cases. Finally, I would document these benign, non-aggressive features and refer the patient to orthopedics for clinical follow-up and prophylactic stabilization if a pathological fracture is imminent.